Hello, good evening, everyone, and welcome to the third edition of the National Neonatology Forum National Level Journal Club. This is an online journal club which is held every month, and this activity was only started this year. The purpose behind this journal club is that nowadays we have a large number of centers in India which are offering various kinds of training programs in neonatology, including DM, DNB, DRNB. There are fellowships of both the NNF as well as the IAP. And of course, there are a lot of young faculty members and even people in the private sector who are interested in research. And quite often they don't get an adequate, suitable platform to be able to understand research methodology, and to learn how to critically evaluate published papers. So for this edition of the NNF Journal Club, we are extremely happy to have AIMS Jodhpur as the host institution. From AIMS Jodhpur, the local faculty member is Dr. Neeraj Gupta. He is a senior neonatologist. He is an alumnus of PGI Chandigarh, and his areas of interest are delivery room interventions. He's a prolific researcher himself. As an external expert, we have Dr. Sindhu Shivanandan. She is a senior consultant in Kaveri Hospital in Chennai, and she is very much interested in systematic reviews in grade-based evidence. She has contributed hugely to NNF guidelines, uh, and various other uh, guidelines of other organizations. So with that, I now hand over to Dr. Neeraj Gupta, who will introduce today's presenter, who is a student at AIMS Jodhpur. Uh, Over to you, Dr. Neeraj. We are also happy to have with us our National Secretary, Dr. Amit Upadhyay, who will conclude the session at the end of the session. So over to you, Dr. Neeraj.
Thank you, sir, for the kind words, and I am thankful to the National Neonatology Forum for giving our department at AIMS Jodhpur this opportunity to present. And this time, in continuation with the previous two sessions, we have chosen diagnostic study to discuss. And previously, we have discussed randomized controlled trial and a cohort study. Now, since often we keep on encountering these kind of questions in terms of what is the diagnostic utility of new test as compared to some gold standard, often we are confused with the terms like sensitivity, specificities, predictive values, and ratios, likelihood ratios. So that was the reason to choose this article this time. And of course, it also shows a dilemma in terms of the utility of CSF parameters in diagnosing meningitis in newborns and early infancy. So this article will be presented by Dr. Pashupati. Dr. Pashupati is with us for last 2 years. He is in fourth semester doing his DM residency in neonatology with us, and a very great, I would say, having good clinical acumen and a very keen interest towards research. And so I hand over to Dr. Pashupati. Over to you, Dr. Pashupati, for presentation.
Dr. Pashupati, you can share your slides, and you can also put your own video on so that we can see you. Yes, your slides are visible. You have to make it full screen.
Yes, sir. Is it visible, sir?
It's visible, yeah, and you're audible. Make it full screen. Yeah, it's full screen now. You can start your presentation.
Good evening to all respected faculties and colleagues. So today I'll be presenting the NNF Journal Club of this month. So title of the article chosen was about the predictive performance of cerebrospinal fluid parameters for diagnosing of meningitis in infants, a cohort study. This was published in BMJ under Archives of Disease in Childhood, which was published on 29th October 2024. So moving on to the background of the study, as we all know, the gold standard for diagnosing any infection is isolating that organism through culture sensitivity. and or by PCR. And but this scenario will not be applicable for any sick children or any neonates, because there is a high chance that there will be hemodynamic instability with thrombocytopenia or DIC, so that antibiotics will have a higher priority when compared to lumbar puncture. This will make the CSF sterile within hours. So this will help. This will give a falsely negative result, which will not help in diagnosing meningitis. So we can have a presumptive diagnosis of meningitis by using other CSF ancillary investigations, like through CSF cytology, by seeing CSF WBCs as well as their neutrophil counts, along with their CSF biochemical parameters like CSF protein or CSF glucose. So, but however, there is the optimal cutoff for diagnosing meningitis is still unclear, and how to interpret these parameters is also still unknown. So coming to the previous studies, so many of the reviews have mentioned the upper limit of CSF WBC in neonates were 20 to 22 per millimeter cube. For infants 1 to 2 months old, it was 15 per millimeter cube, and for older infants and children, it was 5 per millimeter cube. And there was one retrospective study which was conducted in neonates more than 34 weeks, between 0 to 150 days, and if they have taken a cutoff of more than 21 cells per millimeter cube, they have missed almost 13 percentage of bacterial meningitis in those infants. Also, the sensitivity of this WBC in diagnosing bacterial meningitis was 79 percentage and 81 percentage. So there is a clear-cut gap in current CSF threshold for diagnosing meningitis in young infants less than 3 months old. So this requires a detailed review. So the research question is, what is the diagnostic yield in terms of sensitivity, specificity of CSF parameter values for identifying cases of microbiologically confirmed meningitis in children under 3 months? So this methodology wise, this was a multicentric study which was done in two tertiary perinatal centers, the Royal Children's Hospital in Melbourne and Royal Women's Hospital in Melbourne. And it was a retrospective study which was from which data was collected from the year of 2010 to 2020. And coming to inclusion and exclusion criteria, infants from 0 to 90 days were included, and those with positive bacterial CSF cultures or PCR or viral PCR were included, and those with contaminant CSF. Those with contaminant CSF and CSF from external ventricular device or ventricular reservoir were excluded. Also, control group, they have included babies from same age group 0 to 90 days having CSF results, with babies who haven't received any antibiotics before lumbar puncture was done, and CSF report should be negative either by culture or by PCR. And this they have taken control group, at least one baby per group, per baby included in inclusion group, and it was randomly selected, not through any criteria. So these were the definitions used in this research. So if baby has underwent more than one CSF, first CSF will be taken for analysis unless a subsequent CSF had a positive PCR or culture. And these were the organisms which were labeled as contaminant according to this study, which was Atrobacter species, Bacillus species, Brevibacterium species, Brevandimona species, Cones, Micrococcus, Moraxella, Propionibacterium species, and Viridans group. And blood culture and CSF culture were deemed to be concordant if both were positive for the same organism with a 3-day period, either before CSF culture or after CSF culture, and should have the same susceptibility pattern. And they have defined non-traumatic LP as in CSF cytology if RBCs were less than 500 per millimeter cube. These were the data collected in this research. So demographic data included age, postnatal age, as well as birth weight and current weight. And laboratory parameters included blood culture, urine culture, CSF cytology, CSF protein, CSF glucose, CSF culture, or PCR. In view of non-availability of blood glucose levels, CSF is to blood glucose parameter was not collected. So moving on to statistical analysis planned, CSF, WBC and neutrophil count, glucose and protein were planned to express in median with interquartile range, and sensitivity, specificity, positive and negative likelihood ratios were presented, and receiver operator curve was constructed based on the above parameters, and analysis was done by using Stata software version 16.1, and two subgroup analyses were planned. One parameter was by age and second was through by presence or absence of urinary tract infection. And this urinary tract infection they have included because there was literature showed that urinary tract infection, babies have CSF pleocytosis. So they want to see whether if that is affecting the CSF parameters or not. So moving on to results, there were totally 7,997 lumbar punctures happened through this period, out of which 538, which was 7.6 percentage of total lumbar punctures, were positive, out of which 7 percentage were bacterial, which was 39, and 93 percentage were viral, which was 499. So out of this, uh, so after removing this positive culture from 7097, it will be some 6,560 lumbar punctures, out of which randomly they have selected this 550 controls. So it was controls they have selected not through any criteria, it is mainly by random selection. So moving on to the demographic parameters, this table shows the full demographic parameters in infants less than 3 months old. So first column shows control group, second all meningitis group, third bacterial meningitis, and fourth viral meningitis. So first variable I want to highlight was age. So the median age was almost at the end of first month. It was 34, 30, 37, and 30. And also the interquartile range, the lowest day was 18 days in control group and 16 in all meningitis and 15 in bacterial and 16 in viral meningitis group, which means that we have relatively low number of population less than up to 2 weeks old. Second thing I want to highlight is about gestation age at birth. So most of them were almost full term, 39 weeks, and almost their birth weight was more than 3.2 kg in all groups except bacterial group, where you have a relatively less gestation age when compared to other three groups, which was 38.3 was the median gestation age, and interquartile range was 33.2. Also, the birth weight was also relatively less when compared to the other groups. It was 2.6 kg when compared to other groups having a weight of 3.2 to 3.3 kg with lowest interquartile range of 900 gram. Now moving on to the CSF parameters. Here first, if you can see that both control group as well as all meningitis group, almost both groups have similar parameters with little differences. So, but if you want to see bacterial meningitis group, there was a huge difference. Suppose if you want to see CSF RBC, it was 314 bacterial meningitis, whereas in others it was around 40 to 40 to 48, whereas CSF WBC it was 830 in bacterial meningitis group, and others were relatively less, very less. And when compared to CSF neutrophil, which was 506 in bacterial meningitis group, whereas in other group it was median was 0 to 3 to 4, and for protein it was 3.09 gram per liter, and other group it was significantly less, and same was with CSF glucose also. And a word of caution was mentioned for CSF neutrophil count in control group. In this study there was 40 percentage of 40 percentage of infants who had at least one or more than one neutrophil count in this control group. So this was mentioned specifically, and overall if you can see control group, all meningitis group and viral groups were more or less same when compared to bacterial meningitis group. So this were the organism spectrum obtained through this study. So out of 39 bacterial positive cultures, which was 7.2 percentage, so gram positive bacteria was 4.5 percentage and gram negative bacteria was 2.8 percentage. So among gram-positive bacteria, group B Streptococcus constituted the majority, which was 3.2 percentage, and 17 isolates were group B Streptococcus. In gram-negative, it was E. coli, total 7 out of 15. That 1.3 percentage totally was E. coli, followed by Streptococcus pneumonia in gram-positive group. So coming to viral, it was Enterococcus and Paracovirus, which constituted the majority, 73 percentage and 19 percentage respectively. And among urea plasma, parvum and urea plasma, urea lyticum, these three isolates were there, and all babies were less than 36 weeks. So moving on to receiver operator curve, this was constructed for babies less than 3 months. So it was first for bacterial meningitis. Here in ROC curve, you will have one y-axis and x-axis. In y-axis, it will be sensitivity, and it shows the relation between sensitivity and 1 minus specificity. Or in other words, it is false positivity, true positivity versus false positivity. So here orange curve shows the CSF protein, followed by purple curve which shows the CSF neutrophils, and blue curve which shows WBC count, and this green curve shows the CSF glucose. From this curve you can interpret that CSF protein and CSF neutrophil has the maximum area under the curve, and followed by CSF WBC, white cell count, and followed by CSF glucose, which has a low area under the curve. If you take CSF protein, area under the curve was median was 0.93 with 95 percentage confidence interval was 0.87 to 0.99. Also, if you consider CSF neutrophil count, area under the curve was 8.93%, 0.93 with low 95% confidence interval of 0.87 to 0.98. And same with CSF WBC count, area under the curve was 0.90 with 95% confidence interval of 0.83 to 0.98. However, CSF glucose area under the curve was very low, which was 0.69 with 95% confidence interval of 0.54 to 0.84. This interpretation is mainly if you have area under the curve close to 0.5, then your discriminatory value will be less when compared to other three parameters. So here CSF glucose, it has low diagnostic value when compared to other three parameters. So moving on to all meningitis group and viral meningitis group, as you can see the area under the curve is very less. Both in all meningitis group and viral meningitis group have low discriminatory value in diagnosing meningitis in infants less than 3 months old. So from now onwards, we'll be seeing only bacterial meningitis. So this was a subgroup analysis based on age. So they have compared less than 1 month group, 1 to 2 months group, and 2 to 3 months group. So if in bacterial meningitis children less than 1 month group, they have included all four parameters and they have given the sensitivity, specificity, likelihood ratios, positive and negative likelihood ratios of for all parameters. So here you can see from if you are taking cutoff from anywhere from 5 to almost 40 WBC count, almost your sensitivity is almost same. However, your specificity varies from 44 to 86, and your likelihood ratio also varies from 1.6 to 6.3, and negative likelihood ratio from 0.3 to 0.1. Same with neutrophil count. If you take any cutoff from more than 1 to more than 4 neutrophil count per millimeter cube, your sensitivity is almost same. 94 was the sensitivity, and however specificity is increasing from 52 to 81. Same with likelihood ratio of 1.9 to 5. The same goes with protein from 0.8 gram per liter to 1.4 gram per liter, almost sensitivity of 88% is same in all cutoff. From however, specificity ranges from 69 to 94, with likelihood ratio significantly increasing from 2.9 to 14.1. Glucose we are not taking because it has low discriminatory value, and you can see that sensitivity is also, as sensitivity increases, specificity is decreasing significantly. So coming to 1 to 2 months meningitis group, same for any cutoff from more than 10 to 50, they have almost same sensitivity, 91 percentage. However, specificity varies from 72 to 89. Also, likelihood ratio from 3.8. For neutrophil, for cutoff from more than 1 to more 3, sensitivity is almost 100. However, sensitivity from 60 to 83, and likelihood of positive likelihood ratio of 2.5 to 5.9. And same goes with protein. Any protein cutoff of more than 0.4 gram per liter to 1 gram per liter, they have same sensitivity, and specificity ranges from 3 to 86, and likelihood ratio positive ratio ranges from 1.4 to 7.6. For 2 to 3 months group. So for in same for 3 months group also, sensitivity almost remains same with variable specificity and likelihood ratio in all three parameters in WBC, neutrophil count, as well as pure protein. So here sensitivity almost was same, specificity range is variable ranging from lower value of 21 to 90, 60 to 85, 61 to 95, same with likelihood ratio. So this slide shows the diagnostic utility if we combine all three parameters. So as we all know, each CSF glucose, CSF protein, and CSF neutrophil count has good diagnostic accuracy when compared to glucose. So when compared to, for example, if you take 0 to 1 month old babies, so if you are taking only cutoff of more than 20 WBC count, your sensitivity was 89, specificity was 78, and likelihood ratio positivity was 4. If you have taken only neutrophil cutoff of more than 2, your sensitivity was 94 and specificity was 68 and likelihood ratio of 3. If you have taking a cutoff of more than 1 gram per liter, sensitivity was 84, specificity was 82 and likelihood ratio was 4.8. Next, if you are combining first two columns, for example, WBC and neutrophils, cutoff of more than 20 WBC with more than 2 neutrophils per millimeter cube, your sensitivity is almost same, 88. However, specificity is increasing. You can see it was 80. You can see it is 83, and likelihood ratio is also increasing. It was 5.3. So next, if you are combining WBC with protein, and sensitivity is almost on the same level. However, specificity is increasing, 91, and your likelihood ratio is also increasing, 9.1 from 3 to 4. So if you are combining three parameters, all three, more than 20 cutoff with the neutrophils of more than 2 and protein of more than 1, you can see almost sensitivity is almost 85 to 80 to 85, and however specificity is increasing significantly from to 93, and your likelihood ratio is also increasing very significantly to 12.1. And same goes with 1 to 2 months group also, 2 to 3 months group also. So almost your sensitivity remains same. If you're combining three parameters, your sensitivity remains same. However, your specificity and positive likelihood ratio is increasing if you're combining each and every if you're combining parameters. So, and then they have compared the current cutoff what was followed in other article. So, as we have already seen, for 0 to 1 month, it was more than it was more upper limit was 20 cells per millimeter cube, and 1 to 2 months it was 15 cells per millimeter cube, and for 2 to 3 months it was 5 per millimeter cube. So, if we are applying this cutoff over this cohort, and it has missed totally 3 bacterial meningitis out of 39 CSF positive bacterial meningitis, which was 8%. So if you are applying this cutoff over this cohort, it has missed 8% of bacterial meningitis. Out of three babies, two were below 30 days. And this two could have, if we are taking combining other parameters, so from neutrophil, we will be able to identify one organism, which is GBS, and with protein, which is also significantly elevated in second baby. So through these parameters, we could have identified meningitis in this population. However, this third baby in whom Streptococcus pneumonia was grown, there was no WBC, no neutrophil, and RBC was zero, and protein was also significantly less. So this if we are taking this cutoff, it has completely missed one case of meningitis, and this baby was also found to be immunocompetent, not immunocompromised. So, and then a subgroup analysis was done for non-traumatic CSF. So here they have included only babies having RBC in CSF cytology of less than 500 per millimeter cube. So an age was 0 to 3 months. So here they have compared various cutoff for WBC and neutrophils and their sensitivity and specificity and likelihood ratios. Here in WBC, there was slight increase in specificity, which if we are including only non-traumatic CSF. However, in case of neutrophils, there was both decreased sensitivity with increased specificity when compared to the group, which has included both traumatic as well as non-traumatic CSF. And author also has corrected CSF WBC counts based on the number of RBC. He has corrected for every 500 RBC for one WBC, and for every 1000 RBC for one WBC. However, it has resulted in the overcorrection of WBC, so it was not advised to correct WBC based on the number of RBC in smear. And coming to the concurrent blood culture positivity, so out of 39, we have 39 culture positive, bacterial culture positive CSF. So out of 39, there was only 35 blood culture available. So out of 35 blood culture available, 26 were positive, so which was 74 percentage. So there were 25 percentage of babies in whom blood culture was negative, however, CSF culture was positive. So also this was the spectrum of organism. So out of 15 GBS, 14 out of 15 CSF culture positive for GBS, 14 babies had blood culture positivity. Same goes with E. coli. Out of 7 CSF culture positive for E. coli, 4 were positive, and all Streptococcus pneumonia babies were positive in blood culture and CSF. And same goes with Klebsiella, Salmonella, and Group A Streptococcus. So among urine culture available, out of 39 babies who had CSF culture positivity, only 30 babies had urine culture available, out of which 3 were positive, and out of 3, 2 were positive for GBS, and it was in both it was in blood, urine as well as in CSF. So coming to the strength and limitation of the study. So this was the large cohort study which was done over a 10-year period, and it has a large proportion of babies who had CSF results without any prior antibiotics. And coming to the limitations of the study, first it is a retrospective study, so there is a high chance for bias. And second, the major limitation of the study was the non-mention clinical status of the baby, and why LP, the criteria for doing LP or criteria for doing blood culture and other clinical status was not mentioned. And also the timing of CSF taken and when it was processed, how it was processed was not mentioned. Also, it has a low premature and low birth weight cohort. Uh, so mostly it was a term baby with birth weight of more than 3 kg, and this and also term versus preterm was not analyzed because there was the preterm cohort was very less, and there was only 2% of babies who had underwent bacterial PCR when compared to viral PCR, which was relatively more, and only there were few bacterial meningitis which was identified through culture because bacterial PCR was done only in 2% of the babies. So these were the limitations. So here, author conclude the research by saying that combination of parameters will have a higher diagnostic yield when compared with a single parameter. So among single parameters, as we have discussed, CSF protein, CSF neutrophil count, and WBC have a good diagnostic accuracy, and CSF glucose have a low diagnostic yield when compared to other single parameters.
Thank you, Dr. Pashupati. So over to you, Saurabh sir. Over to you, Saurabh sir.
Yeah, thank you. Just struggling a bit with my video. Yeah. So thank you very much. It was a wonderful presentation, very nicely, calmly presented. I would now request Dr. Sindhu to take up some teaching points from this presentation. And after Dr. Sindhu is finished, Dr. Neeraj will dwell a little bit about how, is this applicable to our sort of settings in India, and how, whether it could be used in his own unit, for instance. So we will first start off with Dr. Sindhu. Over to you, Dr. Sindhu.
Thank you so much, sir. So in this particular article, we were looking at the diagnostic performance of CSF biochemical parameters and WBC count. WBC count, neutrophil, protein, and sugar. These are our index tests. And the reference standard here was the CSF culture, which was either bacterial culture or the PCR, either for bacteria or for virus. So we heard about sensitivity and specificity being spoken of in great detail. Sensitivity refers to the number of true positives among those who have the disease, and specificity is the number of true negatives among those who do not have the disease. In addition to sensitivity and specificity being mentioned, there are two important learning points that we get from this diagnostic study, which helps us in clinical application. These are what we are going to see. Next slide, Pashupati. Yes. So we also read about likelihood ratios being mentioned in addition to sensitivity and specificity. How does it helps us in our day-to-day practice? So sensitivity and specificity, they are fixed for a particular test. They do not account for pre-test probability. Pre-test probability is the usual prevalence of or the usual probability of that particular disease in the population of interest. So in this study, if you had seen, we had 7.6% positivity of meningitis. So let us take that the baseline prevalence or the probability is 7.6%. So we will not get it is sensitivity and specificity are fixed for a particular test, and it is unaffected by the prevalence of the disease in the population. If we have to choose one particular parameter which can combine both sensitivity and specificity, that is likelihood ratio. So we'll see what it is next. Second, sensitivity and specificity will tell us how good the test is, but it does not tell us what is the clinical application. So whereas likelihood ratio will directly help us, given the test result, what is the probability that my patient has the disease. So sensitivities and specificities work well in population level screening, but likelihood ratios work well for clinical decision making. So we'll see this in the example that follows. Next slide. Pashupati, next slide. So positive likelihood ratio positive is sensitivity divided by 1 minus specificity. So in this particular example, The pre-test probability is 7.6%. Pre-test probability of having meningitis in the study population is 7.6%. Now let us take one particular test, that is, that particular baby has a CSF protein which is more than 1 gram per liter. So what is the likelihood ratio from this particular study? The likelihood ratio is 4.9. So how am I going to use it in my particular index case? Next slide. So I am going to plot this in Fagan's nomogram. So in this Fagan's nomogram, you have the pre-test possibility. So at the onset of symptoms or when I do the CSF examination, there would be some clinical suspicion or the baseline prevalence. So here I have taken it as 7.6%, which is the baseline prevalence, and my likelihood ratio when the CSF protein is 1 gram per liter. So the likelihood ratio here is 4. So here, this is the likelihood ratio, which is 4. So what is the parameter? So from 7.6, it increases to 28%. So in this particular index case, having a CSF protein, which is more than 1 gram per liter, helps me to diagnose, have a greater suspicion. So the probability increases from 7.6% to 28%. Now I can be more confident of a possibility of meningitis. So it will help me start empirical antibiotics. Now let us take another scenario that I have WBC count, which is more than 20. I have neutrophil count, which is about 2. And my protein is also more than 1 gram per liter. So the study showed that when we have all the 3 positive, the likelihood ratio becomes 12. So that is another scenario where you see this blue line. So from a pretest possibility of 7.6%, it becomes 50%, which is all the more likely that I should not waste time and not wait for culture, but go ahead and start the antibiotics. So this is how, so using only sensitivity and specificity will not help me in a clinical decision making, but when you have likelihood ratios, using the pre-test possibility and this Fagan's nomogram, we can confidently initiate antibiotics. Next slide. The second learning point that we get from this study is the use of ROC curves for appreciating the diagnostic test parameters. So why it is important? So we can compare a lot of parameters. So in this particular graph, we have compared the WBC, neutrophils, protein, as well as the glucose. So the ROC curves clearly show that neutrophils and protein have better discriminative ability compared to white cell count, and the glucose does not have, as opposed to our usual assumption, it does not help us that much in diagnosis of meningitis. So this justifies the study's recommendation to use a combination of parameters rather than just rely on WBC count. Next slide. It also helps us in using optimal cutoffs. So when our the parameter is a continuous value, for example, here we have the WBC count, neutrophil count, or the protein value or glucose value, they are in a it is a continuous variable. So here, when we plot ROC curve, we can choose a value which is to the top left corner. So we can find a trade-off between sensitivity and specificity. So we saw from the tables that were presented that for values starting from 20, 30, 40, the sensitivity was the same and the specificity was a bit variable. So the study still went ahead and chose a WBC count of 20 for the diagnosis of meningitis. So here it helps us to choose a particular value and we can visualize which particular value is best. So even when choosing a value of 20, the study had missed 8% cases of meningitis. So going on to a higher cutoff, we would be missing more cases of meningitis. So they chose a 20 for that 0 to 1 month age group. So here we can visualize and choose the optimal cutoffs, see which is the best trade-off between sensitivity and specificity. So it evaluates all possible cutoffs. So that's another important point that we learned from this particular study. So compared to the ROC curve versus just sensitivity or specificity, the ROC curve plays an important role. One, we can identify the best CSF marker. So neutrophils and protein were more reliable that we were able to identify, and we can compare the overall performance of number of other parameters. So here it was not a single index study. We had 4 parameters. The 4 CSF parameters, we could compare and contrast and choose the best performing index test. And we can also choose optimal cutoffs. So the age-adjusted WBC cutoffs for WBC, neutrophils, and protein, they were able to choose based on the ROC curve. And it can also guide clinical decisions. We were able to show that combining 2 or 3 tests would be better compared to a single WBC parameter. So the ROC curves as well as the likelihood ratios are important study points from this particular article rather than just focus on sensitivity and specificity. Thank you, sir.
Thank you very much, Dr. Sindhu, for explaining it so well. Who would be dealing with the checklist? Would it be Neeraj? Would it be Dr. Pashupati?
Yes, sir.
Yeah. Okay, over to you, Dr. Pashupati.
Yes, sir.
So this is a publication checklist for diagnostic studies. Yeah, please go ahead.
So, moving on to the CASP checklist for diagnostic studies, did the study address a clearly formulated research question? So here, what we have considered was whether the question should include population. So this was defined, and test, also the setting about research, and also the outcomes has been clearly mentioned or not. So author has clearly mentioned all these 4 components. So it will be yes. And second, was there a comparison with an appropriate reference standard? So here the reference standard was blood culture, and here it was compared with the gold standard blood culture and all PCR, and it is available indicator in the circumstances. So here also it goes yes. And third question, did all patients get the diagnostic test as well as reference standard? So here both inclusion and exclusion criteria started with blood culture positivity and negativity. And so here it was considered whether it was received regardless of the results of the test of interest. So here also it was yes. So it was done in both control group as well as in uh, positive group. Fourth was, could the results of the test have been influenced by the results of reference standard? So here, whether blinding was done or not, whether the tests were performed independently, or could there have been any review bias? So here we can't tell because it was a retrospective study, and here blinding was not in. We cannot comment on blinding, and whether the test was performed independently. Author didn't tell about whether what is the criteria for doing test or what is the clinical condition of the baby. Also, review bias, we cannot. He didn't. Control group was selected on random basis, but we cannot rule out whether review bias or any other selection bias was there or not. So we cannot tell. And fifth question, is the disease status of the tested population clearly described? So this was definitely no, because no presenting symptoms, disease stage of severity, and comorbidities like presence of IVH or presence of hydrocephalus was not mentioned, and also the differential diagnosis was also not mentioned. So next question, were methods of performing the test described in sufficient detail? So whether a protocol was followed for doing the test, and it was no, because what was the indication for doing LP, lumbar puncture or blood culture, was not mentioned, and how it was done, when it was done, when it was processed, was also not mentioned. So it was no. So what are the results? So are the sensitivity and specificity and likelihood ratios presented, and whether the results presented in such a way that we can work them out. So this was yes, because we have various cutoff with varying sensitivity and specificity and likelihood ratios presented, and both ROC curve as well as the specific cutoffs were presented. So it was yes. So, and how sure are we about the results and consequences and cost of alternatives performed? Could they have occurred by chance? Whether confidence limits were reported, and what are they? So, this they have mentioned completely with confidence interval. So, it was yes. So, we are sure about the results with confidence limits and consequences and cost of alternatives performed. So, this CSF, other our CSF protein, glucose, and other things we are routinely performing. So, there is no serious consequences or cost involved in doing that alternative. So, moving on to generalizability of the results.
So, when we talk of generalizability, the first and the foremost thing is that whether the study is internally valid or not. Only if the study is internally valid. Internally validity means that yes, the study has been done in the right way and we can trust on the results. If you can't trust on the results, then there is no question of uh, generalizing those results to your population or any other population. Once we are sure that yes, the study is internally valid, then we say that okay, we need to look at whether we can generalize the results to our population or similar kind of setups. Now, what Dr. Pashupati just highlighted through that CASP checklist, except that we are not sure that these babies who are between 0 to 3 months, assuming that these are those babies only who were where the clinician believed them to be septic and they warranted lumbar puncture, assuming that, and the second assumption being, since again it is not available here, that this was done in a blinded fashion. Blinded fashion means that the results of the gold standard test, which is the CSF culture or the PCR of the CSF, and the results of the diagnostic test in question, which means the CSF counts, whether it is WBC, neutrophils, or the proteins or the sugar. The person who is doing the diagnostic test, he or she should not be aware of the results of the gold standard test. That means the PCR results of the blood culture. So since this blinding, we are not sure, but assuming that yes, it was blinded and the population in which this test has been done was actually the population in the real life situation also where LP is warranted. With these two assumptions, if we assume, then we say that yes, this study is internally valid. Now, with this assumption that yes, this study is internally valid, let us move to the generalizability. Now, when we talk of generalizability, we first need to see whether our population is similar to the kind of population which has been enrolled in this study. Now, as a neonatologist, most of us, virtually all of us as a neonatologist, we are talking of babies who are either preterm, especially the very low birth weight babies who are being managed by us in our neonatal ICUs, or sick babies who have term babies who have asphyxias or heart diseases. Unlike this study where the median age is 30 days and they all are term babies. If we see the gestational age in the results which Dr. Pashupati showed, the median age is 30 days and the interquartile range, the 25th quartile was 14 to 15 days, which means these all are bigger babies and term babies and presenting late. So the population which has been addressed where the LP has been done is very much different from the population which we are dealing in our NICUs. So that is one issue here. The second issue here in terms when we look at the generalizability is that if we see the cause of meningitis, here only the 7% of cases of meningitis are bacterial, whereas 93% are viral. Unlike our setups of ICU, neonatal ICUs, where we primarily deal with what we say the bacterial meningitis to a reasonable extent. And sometimes we do encounter fungal meningitis also. virus is highly unlikely in our setups unless there is a sort of epidemic which we saw like in COVID pandemic sort of things. Otherwise, by and large, the pathogen profile in our setups in NICUs when we talk of meningitis is bacterial plus minus fungal rather than this. So because of the overall bacterial being less and then it is predominantly viral population which has been addressed in the study. Moreover, if we try to look at these bacterias, out of 39 bacterias, 17 are group B streptococcus, GBS. Again, unlike our systems where we are struggling with predominantly Klebsiella pneumoniae or Acinetobacter, crabs and all that, and maybe then E. coli and few gram positives. Here, 17 are GBS and 7 are streptococcus pneumoniae. Again, which is very much different. Only the E. coli cases are 7 cases. So even among the small population of bacterial meningitis, the kind of bugs which are there in this study is very much different from our kind of ICUs. Then another challenges in our setup is that so many times it happens we take a decision, we start antibiotics being the baby being sick. So at that time, so many times we are not able to do the lumbar puncture upfront because of the level of sickness or the baby has bleeding manifestation, thrombocytopenia. So we wait, we give antibiotics for 24 hours and once the baby gets stabilized, only then we are able to do that CSF. Whereas in this population, the CSF, the lumbar puncture was done upfront before, even before the first shot of antibiotic. So when we give antibiotic, definitely apart from making the culture sterile, it can change the values of these parameters, both whether it is we talk of counts or whether we means the WBC counts or neutrophils or we talk of the protein content. Moreover, in our setups, the PCRs are not available. Whatever is available is the CSF culture. So considering all these factors, our patient population is very much different from this Australian cohort in which they have done this. So it is not possible for us to extrapolate to our population because of these differences in the population which I have just highlighted. Maybe this can be taken to some extent by the pediatric intensivist who specifically deal with 1 to 3 months of age and babies being febrile coming to their emergencies. But at least for the neonatology perspective who are working in level 2, level 3 neonatal ICUs, this is not there. The third component when we talk of generalizability, if the population fits, like here in this condition, the population doesn't fit. Our population doesn't fit except for the pediatric intensivist to some extent. Again, here the viral is very high as compared to even the pediatric intensivist which they see in our country. If suppose this would have been fulfilled, this condition that the population would have matched, then one try to look at the factors like whether this kind of toolkit is available or not, and if it is available whether the expertise is there or not, and if the expertise is there whether the country or the system can afford it or not. So lumbar puncture anyways is that there is no separate thing which is required, which is easily available in most of the setups, at least the tertiary level setups if not level 2 setups, and the cost is also not a huge issue. So those issues are not there, but I think the extrapolation, because the population being different and the pathogen profile is different, so we cannot extrapolate these results to our set. Over to you, sir. Saurabh sir, over to you, sir.
Yeah, thank you. Neeraj, that was beautifully explained, the whole concept of generalizability. I think you really touched upon those points extremely well. I would now request Dr. Sindhu to take up the questions which are in the Q&A box, which have been sent by the participants. And I would encourage the participants to put more questions, as we go along. So you have to start with a question by Dr. Vivek Kumar. Can you see that question, Dr. Sindhu?
Yes, sir.
Yeah.
Yes, sir. Here, Vivek Kumar has asked, why select only 550 controls? Would having 2 or 3:1 controls better? So in this particular study, we had 1:1 control. The choice of controls versus cases generally depends upon one, feasibility, second, the practicality of a particular test. So in a prospective study, we may just end up using 1:1 control. When we increase the control to cases as 1:2, for example, if we have 2 controls for one case, then the power of the study increases slightly. For example, it may increase by 20% more. And if we increase 1:3, it will further increase, and it will reach a point whereby having more controls would not do much improvement with respect to the power of the study. So generally the maximum is 1:4. People don't generally go beyond 1:4. 1 is a generally accepted baseline value for a particular study. In retrospective studies, we may have the possibility of choosing more controls, and number of cases in this particular study, overall number of meningitis, both bacterial as well as viral, was 500, which is pretty much a good number. So I think they just could chose 1:1. Any other points, sir? What do you think?
No, I fully agree with you that it kind of plateaus off beyond 1:4. There is no further advantage of having 4 controls than 1. And you're absolutely right that it improves the power of the study. So as a result, what would have happened had they had, say, 3 or 4 controls? It is the confidence intervals which would have kept narrowing the more number of controls that you had per case. Yeah, go on with the next question.
Sure, sir. The second question was viral panel done in all CSF for diagnosing viral meningitis. So so as far as from the method section that we know that for all cases of viral meningitis were diagnosed using a positive viral PCR. But for the bacterial cases, which were 39 in number, we are not sure whether a viral PCR was done for them also. So because it is a retrospective study, this is the information that we have. And Dr. Sujit asks, should we do correction for RBC and protein in case of traumatic CSF? The answer is no. So although they had tried to see whether correcting for adding 1 WBC for every 500 RBCs. So it is not correct, and it should not be done. Traumatic CSF, we should not correct. And Vivek Kumar asks, would these values change based on organism, as we mostly see Klebsiella and E. coli meningitis? The answer is, of course, yes. They have 3 ROC curves depicted. One for all cases of meningitis, second one for bacterial meningitis, third for viral meningitis. When we look at these 3 subdivisions, we see that the accuracy for most of the parameters are much better when the meningitis is bacterial compared to viral. So, of course, in our setting, we see more of gram-negative meningitis. So, it may reflect or it may be closer to the ROC curves for bacterial meningitis. There is one question on likelihood ratios. So, likelihood ratio simply means that what is the probability of having a positive test in persons with disease compared to the probability of having a positive test in persons without disease. This is simply sensitivity in the numerator and 1 minus specificity in the denominator. So it is a bit, so for example, let me give you an answer. What is if the likelihood ratio is 4, how does it help me? So if the test is positive, it is 4 times likely, and likely to 4 times it is highly positive in a person with disease compared to a person without disease. So that is how the likelihood ratios are interpreted. So when we have, it will also help us to rule in and rule out a disease. For example, if the likelihood ratio is 10, then there is a strong possibility of having a disease. So we can even rule in that, yes, the disease is highly possible. But when the likelihood ratio is 0.9, 0.1, then we can even rule out the disease. But in values which are between, we are only moderately sure. When the likelihood ratio is 1, there is no difference between, it does not offer anything. So it is, it does not differentiate. The test does not help us to differentiate people with or without disease. So can you make it much simpler, sir? likelihood
No,
ratios?
I think you've done it well. And of course, this requires a slide and actually showing it. But basically, a likelihood ratio for positive test is the ratio between the true positive rate and the false positive rate of the test. So the more the true positive and the less the false positive, the better is the test. So as you said, likelihood ratio of 10 means that the true positive rate is 10 times more than the false positive rate. So that makes it a very good, extremely good test. And of course, likelihood ratio of a negative test is the other way around. It's the false negative rate of a test divided by the true negative rate of a test. So you want to have very few false negatives. You want to have a lot of true negatives. So you want negative likelihood ratios which are very small, very, very lower than the value of 1, close to 0.1. So yeah, that's basically it.
There's another question. With only 39 bacterial cases, how reliable are ROC estimates? Could type 2 error affect conclusion? So when we look at only bacterial cases, the estimates are less reliable. This is seen from the confidence interval. So when we look, that sensitivity was 78, but when you look at the confidence interval, they are very wide. So the confidence intervals are very wide because of the lesser number of cases. So we could have gotten a narrow confidence interval and told with confidence, yes, the sensitivity is much closer to this number of 78 had we had more number of positive bacterial meningitic cases. Should they have done sample size calculation? Ideally, yes, for diagnostic test studies. Here they had looked at a lot of index tests and their numbers were huge. They had done a retrospective study over a 10-year period from 2 centers. So 500 number of cases and 500 controls. That was pretty much a good number. That's what I think, sir.
Yeah. I mean, even without doing a sample size calculation, we can offhand say that, this number would be more than adequate. Hello?
Yes, sir.
Yeah.
There's another question. Why the sensitivity of CSF counts remained almost the same despite increasing the cutoff?
Actually, the sensitivity slightly kept decreasing. It was as Pashupati said, it was in the same range. But if you notice carefully, the number slightly kept decreasing as the cutoff kept increasing. But, it didn't make any material difference to the sensitivity. I think that's what he was trying to say. And I'm sure if you were to go to second, third decimal places, you would see a slight change in the sensitivity as your cutoff is increasing. So it's not as though it was exactly the same. There was a slight decrease as the cutoff kept increasing. Yeah.
There's the next question. In this retrospective cohort study, how meaningful it is for the researcher to be blind to gold standard? Because always he cannot change the values of the index test. So it is very important for the researcher to be blind to the test because this culture, blood culture or CSF PCR is a very hard, it is a very robust reference test. If the test is positive, it's a laboratory-based test. It is based on a pure growth of culture. So it is but however, when you have a subjective test, for example, looking at your ROP examination, CT scan analysis, or your X-ray interpretation, which is highly subjected to a subjective parameter, then it is more important that people are blinded while interpreting the index test. However, in this particular case, it did not matter. In this study, how did authors choose controls? They were randomly chosen because it is not possible ethically to do LP in asymptomatic normal individuals. It is not asymptomatic normal individual. These are babies who have undergone lumbar puncture However, later they were proved to be non-meningitic. Those are the cases that were chosen as controls. What is the utility of choosing controls in diagnostic accuracy study? So we need to have one group where the disease is positive and another group where the disease is negative. That is why controls were chosen. Neeraj sir, would you like to add?
Yes, just to highlight the second point, as you rightly highlighted, that was the LP done in asymptomatic normal unit. So when we do any diagnostic study, it is very important to take only those participants in the study who are actually going to, in the real world situation also, who are actually going to undergo that test. There is no point in taking a normal neonate and doing LP or doing some sort of testing. So in this population, what they have done is there must be some criteria in this hospital that if the baby qualifies for this level of sickness or baby looks septic, only then they will be subjected. So they have rightly done. So these are not asymptomatic babies. These must be symptomatic babies where LP has been done and turned out to be negative. Carry on, please, Dr. Sindhu, please carry on.
Yes. And there's another question. Can you explain how on combining tests, sensitivity decreases? So yeah, when we combine test, which means that when you combine that the baby should have low glucose, high protein, high WBC count, the neutrophil above the cutoff. In such cases, when we combine test, it is all these things should be positive, no? Then the sensitivity naturally comes down. But when you choose either this or that, then the sensitivity would increase. Can you please interpret negative likelihood ratios clinically? For example, a negative likelihood ratio of 0.1, it is 1 by 10 times less likely that the patient with the with the negative test does not have disease. So it helps us to rule out the disease when the negative likelihood ratio is 0.1. What about Elizabeth Kingia meningitis, where CSF glucose level is in single digit almost every time, which helps in diagnosing meningitis most of the time. But in ROC curve, glucose was the least to be considered. So in this particular test didn't show that CSF glucose had discriminatory value. The authors themselves acknowledged that, as opposed to usual belief that CSF glucose values are low in meningitis. In this particular study, it didn't turn out to be. The one reason may be the higher proportion of viral meningitis cases in this particular cohort. How to interpret the CSF when it was done at day 7 of antibiotics because of the baby's sickness level. It is very hard to interpret such CSF in babies who are already exposed to antibiotics, especially for these many days. Even within few hours, the CSF can become sterile, but PCR test may still help in diagnosing. So these are so it's very difficult to interpret such CSF.
Yeah,
So yes, sir, one more point. All said and done, even though we place so much importance on the diagnostic test properties of these CSF, WBC, and we should remember that there was one case of meningitis, especially by pneumococci or something, which had very normal CSF count. So even if CSF parameters are normal, the clinical index of suspicion on a case-by-case basis will always help you in diagnosing meningitis. So that's one point to note for all tests. Yes, sir. Thank you, sir.
Yeah, there's one more question which just been typed. Which is better if you can.
Which is better, likelihood ratio or predictive value in terms of predictive biomarker identification? Positive predictive values and negative predictive values. So predictive value is among those with a positive test, what is the probability of those having disease? So predictive values are highly influenced by the prevalence of disease in a population. So that's one thing which is important to note. Likelihood ratios will help us in clinical decision making. So for your patient, if the test comes positive, what will you do with that particular test? So in individual clinical decision making, likelihood ratio is better.
Yeah, thank you very much, Dr. Sindhu, for taking up all those questions so thoroughly. I think we have come to the end of the questions that were in the participant Q&A box. Thank you both, Dr. Neeraj, Dr. Sindhu, and to Dr. Pashupati, and thanks to all the participants for very actively asking questions and clearing their doubts. I now hand over to Dr. Amit Upadhyay. Dr. Amit.
So there are some questions in the chat box as well.
Oh, there's Dr. Sindhu, can you see the question in the chat box? I think.
What is the cutoff of likelihood ratio positivity where we can consider the test clinically significant? So we spoke about 10 being a very good indicator. Somewhere 5 and above would be a strong clinical suspicion. Between 1 to 5, your pre-test probability will also be considered when you place. And I think between 1 to 5 or above 1 to up to 5, the clinician's decision also comes into play. What to do in cases of grade 2, grade 3 IVH with respect to diagnosis of meningitis? We would get a traumatic CSF in such cases, so cell counts are not reliable. It's known that in hemorrhagic CSF, the glucose levels are very much low, so it's difficult to diagnose. So in such cases, we should rely mostly on culture or PCR. What is the cutoff of platelet count below which it is dangerous to do CSF? I personally feel anything below 1 lakh, it's a bit tricky or unsafe to do lumbar puncture. Sir, I think those are the questions.
Those are the questions. Okay.
Yeah.
Yeah. Thank you very much. Thank you for taking those extra questions. And over to you, Dr. Amit.
So it was a wonderful journal club, and it's a very commonly used discussion in our rounds that, okay, we have the CSF and how do we interpret it? Should we upgrade the antibiotics or should we continue the same? CSF cultures over here are very, very unlikely to be positive, even if blood cultures are positive repeatedly. So this has been our experience. We have now started doing CSF cultures in the Bactec blood culture bottle itself. So, sir, what is your experience about
we invariably do it. We invariably inject the CSF into
in the
Bactec culture bottles. The yield is higher. And of course, prior administration of antibiotics decreases the yield, and sometimes it's unavoidable. You can't do the CSF in sick babies. Yeah.
So what is the approximate CSF positive percentage?
Yeah, it's very interesting that whenever we have looked at our data retrospectively, like this study, the culture positivity rates are very low. They're around 3% in our center. Whenever we have done prospective studies, that means somebody has actually been going and ensuring that things are being done correctly, the positivity rate goes up. So it's somewhere in the range of about 7% to 8% when we looked at both culture and PCR for research, in a research mode when you are doing, it's prospectively. So there is a difference. In fact, right now we are doing a QI project to, see how we can improve our culture positivity rate.
Okay, sir. So, does doing CSF PCR add on to if you have, if as a question was there, if you're doing CSF on day 7 or day 10 because of any reason, or earlier it was traumatic, and subsequently it has now cleared out. So does adding PCR?
Nobody has ever actually answered this question. We had done it a long time ago on blood, that if after giving antibiotics you do PCR, is its positivity rate better than blood culture? And the answer was no, because at least in blood, the body has extremely efficient systems of getting rid of free floating DNA. So as soon as you have bacteria which have been killed by antibiotics and their DNA is free floating, it almost instantaneously disappears from the bloodstream. The body has very, very efficient systems to get rid of it. So it's tough to get a PCR positive after you've given antibiotics. Yeah. Yeah, I think we are on 9:20 now, so we'll probably have to wind
Yes.
up. Amit, yeah, maybe you can
So
make some
we
concluding
should
remarks.
wind
Yeah.
up now, and next time it is important to note that we are having a change in the day on which we are conducting the journal club, and for next time it will be on Fridays, the
The
last Friday
last
of the
Friday.
month. Yes, so that will be 31st of October. So all are invited for the journal club on 31st of October, same at 8 p.m. or 8:30 p.m. Is it?
8 p.m.
8 p.m. Yes.
Yeah.
So 8
8 p.m.
p.m. on the 31st of October. And with that, I would just like to thank our presenters, Dr. Neeraj, Dr. Pashupati, our regional club chairperson, Dr. Saurabh Datta, for coordinating everything with all the speakers, and Dr. Ramesh, Dr. Pratima, for being there all the time. And with that, we close for now. Thank you, everybody. Thanks all the participants who had joined in. And the Journal Club is nothing without you showing interest in joining us. So we expect next time even more people to join over. Thank you.
Thank you. Thank you very much. Good night, everybody.
Right, sir.
Good night.
Everybody.
Thank you.
Good night, sir. Thank you.